In this presentation, we discuss a young man with a severe head injury who developed malignant brain swelling during a decompressive craniectomy. JY is a 39-year-old male who fell from a church roof, hitting his head on a parapet. He had loss of consciousness, followed by progressively worsening sensorium and a dilating right pupil. CT brain showed a hyperacute right-sided SDH with a midline shift. In view the anisocoria and the progressively dilating right pupil, he was shifted to the operation theatre directly. A right-sided decompressive hemicraniectomy was done. The dura was found to be tense, and on opening the dura, thick, bright subdural hematoma came out under pressure. Basifrontal contusions were sucked out gently by irrigation. When the hematoma was irrigated and freed from the cortex, the brain was looking healthy and pulsations were present. Suddenly, there was severe brain swelling with oozing from the subfrontal region. The brain was now closed with difficulty. A dural substitute was used and skin closure was done with interrupted sutures. The pupillary dilatation persisted after the decompressive craniectomy, and after 12 hours, the opposite pupil also dilated, and he moved on to brain death. Brain swelling after an injury occurs because of many causes. The first is a cellular swelling. There is an intracellular accumulation of fluid which occurs because of failure of the membrane pumps. The membrane pump sodium and aquaporin channels fail because of a failure of oxygen supply, because of calcium ingress, and ultimately because of mitochondrial failure and unavailability of ATP. Another cause is interstitial edema, which is due to a breakdown of the blood-brain barrier. Here, the astrocyte food processes retract because of a metabolic shutdown. Endothelial junctions open up, and interstitial edema occurs. One understated and underappreciated cause of brain swelling is the loss of cerebrovascular reactivity. Cerebral blood flow depends upon the cerebral perfusion pressure, which is the difference between the mean arterial pressure and intracranial pressure. Local changes in the cerebral blood flow depend upon cerebrovascular reactivity, which allows for a coupling of the metabolic requirement with the oxygen supply. This reactivity, the ability of vessels to constrict to regulate blood flow, is through the muscles of the arterioles and the pericytes surrounding the capillaries. The paresis of arteriolar and capillary musculature can result in brain swelling. Mediators of vascular brain swelling are through the circulating blood and also in the subarachnoid cerebrospinal fluid. They include calcium, nitric oxide, vasoactive intestinal peptide, CGRP, substance P, and prostaglandins. When acute brain swelling occurs during a decompressive craniectomy, we think of many things. Could there be a new evolving intracerebral hematoma or an opposite-sided bleed? Is it because of edema, cellular edema, or interstitial edema? Or is it because of a vascular phenomenon, a loss of cerebrovascular reactivity resulting in vascular congestion? I propose that arteriolo-capillary congestion plays a major role in brain swelling, and it is mediated by mediators in the cerebrospinal fluid as well as in the circulating blood. This also brings us to the point that very capable neurosurgeons have recommended cysternostomy as a treatment of severe head injury. Is it possible that evacuating the cerebrospinal fluid from the cisterns reduces the role of mediators of vasoparesis? When recovery is occurring after a head injury or after a decompressive craniectomy, we generally wait for the brain swelling to subside before putting the bone flap back. Neurological recovery and brain swelling subsidence tend to coincide. It is again likely that the return of cerebrovascular reactivity is what results in a subsidence of brain swelling.